see the connection between tax revenue and spending on health and essential services. I believe that the BHCPF will try to make it work. After 10 years of the appropriation of the law, this administration took in the last 1 year, 4 out of the 8 ministerial oversight meetings took place in this administration. And we've been able to put it back on track and to channel the resources to the states. And we signed a compact, and the states, as you saw from the joint review, are meeting up, and we want them to continue with the local government autonomy for local governments also to join us, because it's all of the 3 levels of government that will make this work. So there is no issue of partial implementation, but the issue of the package, the truth is, if you spend 10 and is a limit to what you are able to buy. But as more resources are available, then we can expand the package. At the moment, we're focused on poorest and most vulnerable women, children, primary health care, and specific intervention for cancer and other elements. And so we count on the National Assembly's support to build on that. The question on the anti-snake venom, thank you, Senator. I think we are focused on that, and we did a lot this year, and we will do more. The anti-snake venom, well, it's simple, but it's also difficult, because the snake venom is injected into a ship, and the ship generates antibodies, and then the antibodies are selected and then injected to neutralize the venom when somebody is bitten. But the process has to be very clean, because if it is not clean, the injection can also cause complication for the person. So there's a scientific and safety consideration. But we use the best possible anti-snake venom that we can get, and we will do that in 2025 while working out the technological transfer to be able to manufacture. And the center in Gombe is one that is very much in our mind, and we thank you for whatever support that can be provided. Senator, I think the PTF experience, we said it had some good sides and it had some weaknesses. It's not exactly what we're trying to do. We're using the lessons of the last 25 years globally, but also in here in Nigeria. We're linking the medical relief program to local manufacturing, so that we're buying intentionally from manufacturers that have quality products that can be procured over time and to be distributed to the facilities, the technologies that will ensure that we are able to track who gets it, and with independent verification. I think His Excellency's concern for the cost of medicines informed his decision to approve this as an intervention so that we bring relief. And the idea is, as a local industry gets this market, they are being patronized, they'll produce more, others will come in, the supply will increase, and as the economy improves, patients can be able to afford and insurance will be able to pay for, so that it's not creating a dependency over time. But while that economic trajectory is going up, we have to intervene so that the diabetic, the hypertensive, the child with pneumonia will not die because they are not able to afford the basic antibiotics today. So that's why it's called medical relief program. The federal medical centers, we have taken stock of all of them, and our directors are here. We are focused on the quality of care, to improve the quality of care within the federal hospitals, but also within the private hospitals, as they're regulated by us, and by the states. So in the ministry, now we have a scorecard. The assessment has been done, and we will bring out the scorecard for each of our hospitals. We have put independent assessors for CMDs beyond their control, not the self-reported assessment, to tell our patients fed well, are the facilities clean, do they have water, are the health workers going on time, are the facilities looking good. All in all, Civil Senator, I would say that the Nigerian health sector is in a good place. There are many good things happening in our sector that Nigerians sometimes don't know, and they go to other countries without knowing, and they spend a lot of money when they could have gotten the services here in Nigeria. There are people who have gone to countries in the Middle East and come back to Nigeria to get treated and treated well. And things like stress EKG, there are things that can be done. We have world-class facilities in Lagos. We have some emerging in Abuja. And I urge all Nigerians to look at what is possible within the country, because we are building the infrastructure and we have the qualified manpower. That is why others are taking even the manpower that we have and taking them to other countries, because Nigeria is beginning to improve. But it's not yet there. We urge and we count on the Supreme Committee and National Assembly to help us in this direction. Thank you very much.
Why are they waiting? They find see camera now. They block camera.
Honorable, the procurement for Traffic Abakaliki is ongoing and it will be done before the end of the 2024 budget year in June. You can be rest assured, and I want to assure you, and you must be proud of what the Federal Ministry of Health is doing in Abakaliki. Yesterday we saw a testimony from a woman who was almost going to commit suicide because she had obstetric fistula. But the free fistula program that we instituted meant that she was repaired and she had her life back, and she voluntarily came and gave a testimonial in camera of how this saved her life in Abakaliki. So we're moving forward. More than 1,600 women have had their fistula repairs in just the last 5 months under this program with the NHIA. And the health insurance expansion is for the vulnerable population. And on the supply side, there is capitation through primary healthcare through the states that is ongoing, and the primary healthcare centers and those who are enrolled, they can be provided, you can vet them through MPHCD and NHIA. More than 2.4 million Nigerians have been added to the insurance rolls, and hundreds of thousands of them directly from the Vulnerable Groups Fund and NHIA, based on enrollment. And this is real, and I urge that you can actually access, and if you have folks, the only thing is that we are focusing on the poorest and vulnerable, not necessarily only the luckiest who know one or two people. We're focusing on those who really are very poor in our communities, so that because the burden of disease and death tend to be in them. And that's the idea. The health centers and their functionality, all the states, through impact, have resources for revitalization of their primary health care centers, and the MPHCDA can provide you with that. There are at least 308 that were completed last year. About 2,600 are in advanced stages, but we decentralized the implementation through the states, because we have to do it with the state governments as well. We did not want the federal government to be the one meddling in every state, but that we do it cooperatively with the state governors, and the state governors are very, very much aligned with us and the compact that we signed with them. So in Ebonyi State, Your Excellency, you will find that we have those good relationships. Now, the regulatory role of NAFDA, it's still work in progress. I believe that the NAFDA committee will have engagement or has had engagement with NAFDA. We did provide guidance in terms of streamlining the regulations from NAFDA so that it's easier on the entities that are manufacturing locally. But we have to be careful. There's a way you can lower the regulation that then allows counterfeit and substandard things to be in our market. And in some places, you have many substandard products manufactured here, which can damage. So imagine you have malaria or hypertension, and you take a medicine that doesn't work. That can be deadly, because you think you are taking the medicine, but it's not working. So NAFDAC has to maintain some stringency in the regulation. Otherwise, people can manufacture fake drugs, and they will undermine the ability of the true manufacturers to sell their products.